With the patient prone on a radiolucent table, use AP and lateral fluoroscopy to target the appropriate spinal level, the start point on the facet, the trajectory of the implant, and the entry point on the skin. The AP view should be adjusted to the lordosis of the level being treated. Place the C-arm into a Ferguson angle so the inferior end plate of the superior level being treated appears as a single line. To determine the entry point on the facets, identify and mark the following. Using a guide wire or similar tool, locate the midline of the spine, the inferior end plate of the superior vertebral body being treated, and a line connecting the medial borders of the pedicles of the levels above and below the level being treated. The intersection of these two lines represents the docking point for the access needle. Switching to a lateral view, determine the trajectory of the access needle. This will help determine the entry point through the skin. The entry point is usually a level or two above the level being treated. The trajectory needs to go through the superior and inferior facet and continue through the center of the pedicle into the vertebral body. Once you have determined your docking point on the facet and your lateral trajectory, a midline entry point can be established. In the AP view, mark the point on the midline where a line from the medial half of the pedicle through your docking point on the facet intersects midline with the same line from the opposite side. Once the entry point is determined, make a small midline stab incision to introduce the access needle. The trajectory of the implant will be medial to lateral. The medial to lateral trajectory will be roughly 10 degrees. Insert the single bevel access needle with the bevel facing up. This will help prevent the needle from skiving off the facet. Advancing of the needle through the skin incision is accompanied by repeated AP and lateral fluoroscopy to confirm precise placement of the access needle. Tap the access needle into the cortex of the superior facet. The access needle can be carefully advanced through the superior facet and into the inferior facet, or the inner obturator of the access needle can be removed and guide wire inserted. This will be dependent upon quality of bone and surgeon preference. The guide wire can be driven manually or under the assistance of a power wire driver. Drive the guide wire across the facet joint and through the center of the pedicle into the posterior third of the inferior vertebral body. The wire stiffener placed over the wire at the proximal end of the access needle will help prevent wire bending. Once the guide wire is placed, remove the access needle. With the guide wire placed, extend the skin and fascial incisions to 15 mm for placement of the dilator and working cannula. The fascial incision needs to be incised inferiorly to the skin incision to allow proper placement of the cannula introducer. Prepare the cannula introducer by sliding the working cannula over the dilator shaft while the knob is in position number 2. Lock the cannula into place by turning the knob to position number 1. The cannula introducer is placed over the guide wire and advanced until the dilator is docked on the facet. With the dilator docked on the facet, turn the knob to position number 2. This unlocks the cannula. Press the handle down, sliding the cannula into place. With downward pressure, hold the working cannula in place and carefully pull up on the handle, removing the dilator. Make sure that as the cannula introducer is removed, that the guide wire stays in place. Advance the drill roughly 30 mm to the junction of the pedicle and the vertebral body. Tapping is optional. The Primalock FF facet screw is self-tapping. Make sure the tap doesn't advance the guide wire as the tap is advanced. As a visual reference, the threaded portion of the tap is 20 mm. The screwdriver inner shaft is designed with a threaded distal tip to affix the screw to the driver. This ensures the screw will not disengage the driver while being passed over the guide wire. Seat the tip of the driver into the head of the screw and rotate the knob on the proximal end of the driver clockwise to capture the threads in the head of the screw. Confirm with fluoroscopy the trajectory and depth as the screw is advanced over the guide wire. Be careful not to advance the guide wire as the screw is advanced. Once screw placement has been confirmed, the screwdriver can be disengaged from the implant. Turn the knob on the proximal end of the screwdriver counterclockwise to unthread the inner retention shaft from the screw.